for this year. And I have the pleasure of introducing Tariq Abu-Jaber, who's actually spoke at the first Himss meeting that I ever attended. So he's kind of a staple around here. I've seen him speak several times. So Tariq is the Vice President of Medical Informatics at Harvard Pilgrim Healthcare, the premier nonprofit health plan in New England. He joined Harvard Pilgrim in January of 2012 to establish this new department and foster information-driven strategy for Harvard Pilgrim, including specialized staff, methodologies, and applications. Prior to joining Harvard Pilgrim, he spent 7 years at WellPoint, which is also in the Blue Cross Blue Shield, building out their information management function, developing new data sources, creating decision support solutions, and driving adoption of new models to augment the value of information solutions throughout WellPoint and Anthem, the largest health plan in the United States. Prior to WellPoint, he spent several years directing product management analytics products and services at McKesson Health Solutions. And before that, he was the vice president for consulting services with Cambridge Health Economics Group, a clinical and financial consulting analytic firm with hundreds of U.S. payer and provider clients. Some of the previous activities he's been involved with include nonprofits and education. He has a bachelor's from Cornell University in anatomy and physiology and a master's from Lesley University in community health, as well as a master's in public health from the Harvard School of Public Health with a focus on healthcare management. So I will glad to have him as a speaker, and we'll have Scott, who's our incoming president-elect for this year, give the next introduction.
Great. And please welcome Tariq.
Most important part.
Glad to have you. Good afternoon, everyone. We have a great panel of speakers to wake you up out of your food coma after lunch. So I will quickly introduce the next panelist, Michael Nix. Michael is a leader in the analytics group of the James M. Jeffords Institute for Quality and Operational Effectiveness at Fletcher Allen Healthcare, Burlington, Vermont. Fletcher Allen Healthcare is the academic medical center hub of the Fletcher Allen Partners Network, which encompasses 4 hospitals and multiple primary care and specialty physician practices in northern Vermont and New York. With an academic background in industrial management, University of Alabama, and systems management, University of Southern California, not South Carolina. He has worked for over 30 years in healthcare, including qualitative analysis, quality management, clinical operations analysis, consulting, material management, as well as general hospital data collection and distribution. He is a past 2012 and 2013 healthcare track chair for the MIT annual Chief Data Officer and Information Quality Symposium. He has also taught a variety of business management and finance courses at the college level for over 25 years and is currently a graduate faculty member at Champlain College in Burlington, Vermont, teaching financial and economic modeling. Please join me in welcoming my good friend, Michael Nix.
And it's my pleasure to introduce another New England Himss board member, Todd Brogrow. Todd's the Health Infonet's Chief Technology Officer and provides the technology vision and leadership for all technical aspects of the company, including system architecture, strategic planning, operational systems management, acquisition and deployment, and, not to be left out, data integrity and information security. In his prior role at Northrop Grumman, he managed teams of up to 300 people on nationally recognized projects such as the U.S. Armed Forces Health Longitudinal Technology Application, the largest EMR system in the United States. With over 20 years experience, primarily in directing technical projects, he has provided business and consulting services to a range of Fortune 100 companies, including defense, telecommunications, manufacturing, and natural resource industries. Todd has a master's degree in public administration, is a certified PMP, and a 2012 graduate of the Hanley Center's Health Leadership Program in Maine. He also currently serves on as a director for the New England Himss board. I'd like to welcome Todd.
Hi, my name is Nicole Prejan. I'm from PC Connection, and I'd like to introduce Frank Stearns, Executive Vice President from HIB Solutions. Frank currently serves as Executive Vice President of HIB Solutions, an early-stage healthcare analytics and services company that focuses on helping healthcare organizations provide their performance and the health of the people they serve. Prior to HIB, he served as the senior executive positions in healthcare technology and consulting companies, including Nuance Communications, Allscripts, Cerner, Computer Science Corporation, and Mediquel Systems. His experience includes managing overall business organizations, professional services, product development, and client support services. He is a frequent speaker and lecturer on strategies to improve organizational and clinical performances in healthcare organizations. And Frank holds a Master's of Healthcare Administration degree from Clark University and a bachelor's degree in zoology from the University of Maine. Welcome.
All right, great. Thank you for the introductions. Thank you also for coming back from lunch. Appreciate that a lot. And in recognition of the fact that, as the expression goes, we're the only thing between y'all and cocktail hour, we will attempt to keep it lively. And I think this is actually a really good topic for the last session today because it is by nature just a little bit controversial, and that's what we'd like to do. My intention in facilitating this panel is actually to give you the opportunity, as well as myself, to ask our panelists some questions that might be on your mind, might be bothering you, that might be irritating about this word, this expression we keep hearing, big data. It's kind of become one of those things you hear, your eyes just roll, right, before you even think about it. So we'd like to get into a little more reality about what's going on. That's why we like the title of the session, Big Data. Really? Because a lot of people throw this around like a calling card. Hey, check it out, big data. Yeah, maybe not. So I think we've got three panelists who really have a lot to say on not just the same old data management, and hopefully that'll inspire some questions as well. I'm just going to throw up a few images real quick, kind of to get ideas flowing, and then I'll hand over to Mike. The first test, though, is to see if this little gizmo works.
Can you speak closer to the microphone?
I certainly can. And this little gizmo does work. Good. So, I find myself asking what exactly are big data. Somebody mentioned Tom Davenport. Tom Davenport's written innumerable books on the subject. And a lot of times, big data, it got its name outside of healthcare. We've sort of pulled this one in because it looked fun. And you can see it in consumer, in banking. They're using Facebook and social media and consumerism data and credit card usage and zip codes. We're not doing a lot of that in healthcare. So what I tend to think of it as going beyond these traditional data sources, which for us, let's face it, are claims. Right? Ooh, boy, claims. Yeah. Useful stuff. But we sort of milk that cow dry. And then, sometimes you'll talk about EMR. Okay, good. Well, let's bring it on. Let's hear about it. What else is it? Well, it might be something that just recently became available, and social media is a good example of that. And the ability, or things like Hadoop, which are able to grab large chunks of unstructured data and sift through it very quickly and find nuggets that are useful. Also, what do we learn from other domains? What might retail or finance be doing really well that we go, I can do that too? Now, here's one of these cute things. So big data is not just lots of data. And that's how I often hear the phrase used. So, oh, it's big data. No, it's not. It's just a terabyte of the same old data. So, but sometimes I think it's appropriate when it really gets big, then okay, fine, maybe that's big data. And this notion of poorly structured, I mean, I won't even ask for a show of hands because we'll we'll end up knocking each other over. How many of us have wasted untold hours and dollars, right, trying to structure data that was never made to be structured in the way we need it? I mean, let's just start with claims, right? We're all building these data warehouses and then we mine them to death to learn things they weren't developed to do. So we're repurposing, that's good. But an enormous amount of time, effort, and money go into this, and maybe that's not necessary. And so sometimes it allows us to see things we couldn't see before, and that's, I think, what our panelists in particular are going to have an opportunity to talk about. So the same thing, I'm not going to go into it to take too much time, but many of the things I said, just one other point out. Let's see if this thing works. Ooh, yeah. Genetic data is one of those that comes up that's somewhat unique to healthcare. It is absolutely, I would say, a big data element, and that people are barely touching and are rightfully afraid of getting too involved in this area. And then we also talk about, even within the EMR, people talk about well, we can pull lab data out of the EMR. Well, that's great. That is really great. Maybe biometrics. And those are well structured. What about the stuff that's not structured at all? Like the doc's handwritten notes. Why not? I mean, why not? Probably the best information's there. So we don't need line of sight. That's good to know. Okay, but I guess my only point in this slide is that there's not just one area that can get value out of these sort of new ways of analyzing data. Within a health plan, at least, I mean, we sort of have these traditional domains: the financial side, the insurance side of the house, our clinical programs, our members and our buyers, as well as our providers, the stools or sort of the industry sits on. All of them, in a sense, are begging for better information. I mean, let's face it, I have a health plan background for the last 12 years, provider and consulting before that, and product. But we health plans are actively, and usually by invitation, asking these provider organizations to take on risk. I mean, Joe talked to the people in the earlier panel, all talked about it. Taking on risk, they think they want to, so it's kind of nice. We're on the same side of the tennis court for once. What does that mean? It means becoming little insurance companies, and it's not going to work if you're flying blind. It just doesn't work. You paint the windshield black, you're not going to get where you want to go. So we're trying to make information drive this particular airplane. So here's the question we're going to ask our panel. Is it really happening? Maybe a little. And what are some things I've seen? There's some really great work in predictive modeling. Probably many of us are exposed to. Using different data sources. Sensors are another really interesting one. These wearable sensors. And I noticed at least 2 Fitbit wristbands this morning. I don't have one, but that's okay. And I'm working with a small company that's developing, what's the word? Blanking on the word. Sort of body position sensors for elderly patients. So when they fall down, somebody knows about it. In quality care, I think, is an area where we've been trying to leverage what sort of paltry data we have for a long time. It's been brought up many times today already. How do we measure quality in healthcare? It's still process of care. That's really weak. I mean, we all know it's the elephant in the room. That's not really quality. It's what we've got. Can we do a lot better than that? And similarly for care and disease management, how are we identifying and stratifying members? It's pretty much the same old ways we have been for a long time. You can read this on your own, but I just happened to get in the mail a couple months ago a recent Himss paper in association with IIA, which is actually Tom Davenport's organization. And there were some quotes I pulled out of it that exactly made the same points that I'm relating at the moment. So, cynically put, much of what I read about in the press, maybe yourselves or in the trade journals, is kind of palaver. It's like, oh, look at this great thing we're doing. You read through it and you go, I don't know, that sounds like the same claims analysis I did in 1997. Well, they try to impress me more than that. And I think we have some folks in the room who can. So I want to ask our panel to really tell us what's really happening within the healthcare environment that we're parts of that's doing something groundbreaking. It's moving beyond these traditional data sources and methodologies and outputs to really improve the game. I think that's it. Not going there. Okay. Then, who's going first?
Yeah, I think
Excellent. And can we cue up his deck?
Yep.
Pretty well. And that one advances the slide. The red one's the laser, so don't up there.
Okay.
He just got tased.
By the way, while they're queuing up the slides, I'll just note we did also have Dave Hemingway, a guy who needs no introduction. Hemingway, that's pretty fun.
Okay.
Wenberg, sorry. Unfortunately, he became very ill this morning and couldn't join us. So I think, just so you're looking at your schedule and saying, where's the other guy?
Right, and unfortunately, because David is such an entertainer in addition to being a very smart guy, we have to up our game quite significantly to keep you involved. But I'm going to be talking about this topic, and the first thing I should say, in full disclosure, is I'm a quality type of guy. I live in the quality environment. So most of my comments are going to be really from this user perspective, not so much a originator or people who are involved in the generation of data or some of the intermediary types of activities that many of you will represent. So please understand that when I say, in all sincerity, I am totally blown away with everything I've seen so far today. The panel this morning, as a practitioner, as someone who lives in that space of trying to implement and deal with the use of the data, everything they said is absolutely spot on. It's very seldom that I ever run into a presentation where 100% of what everybody says I agree with. So that's really rare. Now, when we talk about quality in the Fletcher Allen, and I can only refer to Fletcher Allen Healthcare here in Burlington, Vermont, I can only refer to them for one more month, because a month from this coming Monday, we will no longer be Fletcher Allen Healthcare. We will become the University of Vermont Medical Center, and our Fletcher Allen Partners network that you see here will become the University of Vermont Health Network. So, University of Vermont Medical Center, University of Vermont Health Network. Our particular setting, and I didn't want to do a slide, I just wanted to give you a quick understanding, is we are a tertiary care medical center, for those of you who are not familiar with us. We're one of the smaller, but we're not the smallest in the nation. We think we do a pretty good job, and some other people think that we do a really, really nice job. We are part of what's called the University Health System Consortium, which is a collaborative organization that incorporates about 95 to 97% of all the academic health medical centers in the United States. And this past year, we were ranked number 7 in the country. So we try to. I have absolutely nothing to do with that. No. But I did. In truth, I have to give an honest answer. Yes, we have a lot to do with that, because we try as an organization from the very top down to focus on what healthcare means and what the impacts are. The nice thing about living in Vermont, and this is an offshoot of a conversation that we had at lunch today, Vermont is very up close and personal. In this room, there are people that I know that would be receiving health care. I can't go onto, let's say, an OR list and not know somebody or the family of someone. So when we talk about quality of care and doing good care delivery, in our context, that's our friends, our families, our neighbors. Very close and up close and personal. So we try to take that through our processes and apply it in a way that makes sense, that we can leverage what we have. So that's my context. That's where I'm going to be coming from. Hopefully, it makes some sense. Okay.
I don't think this is working as a slide.
Okay, well, see, Tariq, you set me up. You said, push this button.
It worked for me. I don't know what to say.
You know, man.
But that's because you hit him with the laser.
Oh, okay, well, if I hit him again, how about that? But as you just don't want me up here telling jokes, please. Let's try that. Okay.
Oh.
There we go.
Oh, hello, okay, we're back. Okay. Okay, what big data is not? Because everybody sort of talks about big data, and again, I give credit, I don't want to repeat. A lot of what big data, it appears to many people, has to do with size. It really isn't about size. The platforms exist to manage the size. It's a technical issue, but it is not a management or a logical issue. So we're really not talking about the fundamental difference. Data is data, whether it's 100 records or it's 1 billion records. It's still just basic data. How do you deal with it? How do you work with it is the real opportunity we have. And don't let this size issue get in the way. The other thing is that you see this crop up from time to time. It's not about retention of data. In the quality world, we need to retain data literally forever. And I mean, literally a couple of weeks ago, I had somebody ask that we could generate a birth list back through 1964. Couldn't quite go that far back because we didn't have the electronic records that far back. But the idea is that when we talk about big data, we really are talking about a variety of data. We're talking about longitudinally over an extremely long period of time. Now in Vermont, we also have the additional challenge of the fact that we don't have a significantly high volume of our patients are mobile, in the sense that we have long-term relationships with many of our patients over the space of 20, 30, 40, 50, 60, 70, 80, 90, 100 years. We recently had a patient that we've been caring for in our various manifestations for over 100 years. Yeah, he's about 140 years old, and guess what? He was born in the Mary Fletcher Hospital. Okay, so we need to have big data, but we need to manage it. Okay, what is it for us? There's been a significant expansion in data, and I think we're not any different than most other places. Electronic records, we are on the EPIC system. We are making progress toward getting it more user-friendly for our providers, just like everybody. You have to go through those gyrations. We are talking about more interfaces and more interoperability so that we can actually connect the dots more directly, both in the direct care setting as well as in the analytic setting. Now, I should say, we had a data warehouse back in 1991. We actually had a thing called the Patient Circle of Care, which incorporated our then electronic record, our financial, our laboratory, all our ADT, admission, discharge, transfer information, all on a warehouse, all interconnected. The platform wasn't particularly responsive, but we had it all connected. We were a bunch of country bumpkins. We weren't smart enough to know that you couldn't do that. So we just did. We've taken that tradition forward. I've been at Fletcher Allen 25 years this time. So I can really say I've seen it evolve. But the key is that as you identify information that is needed or useful, getting it linked together is critical. And quite honestly, most of the things that we talk about in big data are fundamentally data warehouse objectives and data warehouse opportunities. Overwhelming exponential growth of discrete data is something that has not been well managed in most organizations. They didn't anticipate the growth, both the breadth and depth. We struggle with it. I think everybody struggles with it. You have to get your mind out in front of this exponential growth. Electronic records generate data in prodigious amounts, and they do it 1 million records a day. that type of orders of magnitude. So when we look at what the expansion is, a lot of it is the absolute content that we're talking about. As an example, blood pressure. This is a trick question. What should a blood pressure value look like? Anybody want to go out on a limb? Yes, ma'am.
It's actually two values. It
Um,
has a systolic and a diastolic.
you are partially correct.
Oh, that's better than not being correct.
Exactly. Exactly. Hey, 80% rule. She's pretty close.
Millimeters of mercury.
Okay, I will agree with you, but I'm going to say that you're just trying to get some glory out of her good answer. Okay, seriously, when you talk about what a blood pressure should actually consist of, yes, they are the two values, but do most of you realize that you also need, in a complete setting, you need to understand what the patient position was. That's a required element, but it's not recognized as a required element. When we put our new EHR in about 6 years ago, we actually had 6 different versions of blood pressures. Okay? Now you want to talk about that being really interesting for people like in my area to try to use 6 different ways that we were capturing blood pressures. And to this day, we still don't capture the patient position, because sitting versus supine, etc., those are all clinically important. So there are all sorts of new questions that are constantly being asked. 48 hours ago, our imaging chair said, I need to track follow-ups on our recommended imaging. Okay? Person has a fracture. My radiologist says you should have this re-imaged in 6 weeks. Is it happening? If it's not happening, why isn't it happening? Is it just being omitted, overlooked, or it's not clinically relevant? So things that we talk about, literally new questions are arising every day. So to manage big data, we as quality professionals, you as informatics and data professionals, as well as the finance people that may be in the room, you have to think a lot differently. Okay, starting to get close to the end. There are significant challenges in data quality. Now, as you may have heard from part of my intro, I've been active for several years in the MIT Data Quality Symposium, so I'm really a data quality advocate. The reason being is the minute you try to do something with data and there's a flaw in the data, guess what? You're dead in the water. No matter how good it is, that 98%, that 2% is what kills you. With big data, we have seen an astronomical degradation in the quality of data. Data from good sources has gone downhill at a rapid rate because of the complexities of the data. And we're talking about not only the lack of input controls to where somebody can't put an invalid value in. We had somebody that had a recorded weight, for example, as an adult that was put in grams, not kilograms. Okay, except they left off a couple of zeros if they were going to portray it that way. So things like that, something really simple, it compromises the data. Then that means you can't use it. You've got to find it, you've got to correct it, you've got to correct it in the source system. From our perspective, the way to be appropriate is whenever we find something wrong, we make the people who own the source system go back and change it. That makes us really, really popular. Sometimes it requires a rebilling if it's something on the side of coding or whatever. Clinical systems. notes. We actually, in some cases, our chief medical officer might an attending go back in and revise the medical record, not for purposes of, you know, upping the DRG or whatever, but to clarify the fact that that was not an appropriate note. Okay, bad data, growing at an incredible rate. The impacts of complex multi-dimensional data. I love that term. Nobody knows what it means. So it can be anything you want it to be, okay? The realities are, we're talking about interconnections of data. In the old days,